you guys can keep chatting a little bit, but I think I got the louder voice at this moment. So my name is Libo, Wang, one of the cardiologists at University of Utah. I'm just a humble, normal cardiologist, half the time in the imaging lab. And I have my colleague here, Dr. Ravi Ranjan, who's one of those fancy ablation doctors. Thank you for joining us tonight. Hopefully the food is good. I have not tasted it yet. So tonight, I wanted to talk about atrial fibrillation, not from an ablationist perspective, but from a general cardiologist, diagnostic cardiologist, preventive cardiologist perspective, because often our patients are coming here and they're lost in the process in their different phases of Afib. And I hope you appreciate the memes. If anything you learned tonight, there are memes in this world. Okay, so I do not have any conflicts of interest to start with pertinent to this talk. All my clinical preferences and graphics are of my own. So our goal tonight, I really want to focus two things. We had a thick document in 2023, coming to 2024, the updated ACC AHA guidelines for atrial fibrillation. And I wanted to focus on a lot of the pillars of prevention and kind of convince you that prevention is actually treatment and some of the impacts that we can do for our patients' lives beyond just sending them for a cardioversion or ablation. And I also want to talk about individualizing anticoagulation. There is certainly a good amount of controversy still, but I think we're clearer than ever in the last decade about who to put on blood thinners and maybe still some of the gray zones. So this is a classic patient that we often see, 55-year-old male. He's got class 3 obesity, COPD. He's not too old. He's had a history of tobacco abuse, maybe just half pack a day for 20 years. He's got prediabetes. And his outpatient primary doc reached out and said, look, this guy looks more swollen. What should I do? You know, 5 days ago, you reviewed the chart. You're on the phone with him. He got started for COPD treatment, got steroids, got dual neb, using albuterol, still puffing it 2 to 4 times a day. And he drinks 1 beer on average daily, certainly within the healthy limits that some of the guidelines would say. So the primary doc said, look, he didn't look like he was in heart failure. The patient said he felt swollen in his belly, but they noted a fast heart rate, and you notice the vital signs do confirm that. A 12-lead ECG is obtained, which is something we commonly do. So we're not here to test people on ECGs because everybody is very good at them. This is an EKG showing classic atrial fibrillation, rapid ventricular response. The ventricle doesn't look particularly healthy either. You can see that there's some amount of poor R-wave progression, which is never a good sign, maybe some borderline Qs and a wide QRS, some interventricular conduction delay, and ST changes as well as right axis deviation. So as per usual in cardiology fashion, we get an echocardiogram. All right, is everybody comfortable? Should we send this patient home? They look pretty good. No further recommendations. And so what we see here is pretty marked systolic dysfunction, probably 25 to 30% EF, but it's difficult to assess. He's in tachycardia in the setting of atrial fibrillation. And what I was demonstrating there is a good amount of mitral regurgitation. So what next? You know, the primary doc says, hey, you recommended an echo. We were able to get a slot in. The patient's not currently anticoagulated. This was a recent occurrence. Should we do cardioversion stat? Should we start a direct oral anticoagulant? Or let's get the patient to the ER. He's feeling kind of lousy, though he says, I feel okay, too. Should we get him to Dr. Ranjan for ablation stat? Should we diurese him? Should we investigate possible coronary artery disease? Or should we tell him to stop drinking? And that's the only thing we tell him. And I put this up here because, you know, we're far past the era of step 1 MCATs, right? In our patients, we do many of these things at once. What we shouldn't do is cardiovert at this moment without protection of anticoagulation, as well as left atrial appendage knowledge. So AFib is increasing with age. If you live long enough, some people believe it is purely a fact of age and the stiffening of the heart, fibrosis and inflammation across the lifetime. But we know it's increasing with other risk factors. It is the most common sustained arrhythmia in all adulthood. The statistic below is probably underestimated, right? This is from Medicare data where we're saying after 65 years of age, if you just catch all the people in a random sample of Medicare beneficiaries, 5% will have AFib, 10% over to the age 80, and I would argue both are underestimated when you start digging into the data down that rabbit hole. We know that general mortality association with AFib, and maybe it's not because of causation, but people with AFib probably are in a bad neighborhood in their heart too. Stroke, multiple folds of increase, 4 times in men, 5.7 times in women. Heart failure, highly associated, interestingly enough, more in women, affecting them asymmetrically. And dementia over a lifetime, even in the young patients, associated with long-term cognitive decline and possible dementia. So, right here, I'm not diving too much into the pathophysiology, but we know atrial fibrillation comes predominantly around the pulmonary vein, this embryonic tissue, that under stress, fibrosis, stretch, can produce a very high frequency short circuitry, right? A short circuit, micro reentry circuit, 400 to 600 beats per minute. And the ventricle's just trying to keep up, and we see the irregular heartbeat in the LV and RV. We're gonna get a theme here of the chicken or the egg. A lot of these things can beget AFib, myocardial infarction, development of systolic dysfunction, stress and malignancy, inflammation from chronic kidney disease, volume retention. And we're also gonna see that AFib can worsen heart failure, can worsen renal perfusion, can produce cognitive decline, and certainly the key thing is risk of systemic embolism and stroke. So before we even talk about direct treatment and ablation, this is in our guidelines. This photo right here, this picture right here is in the ACC-AHA guidelines and actually highlights it pretty well. This is how I explain to patients. Look, we should focus on, do we need to anticoagulate? What are some of the risk factors you have, including possible reversible or things that are triggering the AFib? And our current guidelines actually break it down in a number of these pillars, but I'm gonna focus on them very asymmetrically because I think some of these are more modifiable, and I think some of these are more subtle and hopefully convince you by the data. So my argument is treatment is prevention and prevention is treatment. And we should modify all the risk factors, which is what a class 1 recommendation in our current guidelines. Now, this is a favorite photo of mine from the new guidelines. I don't know if anybody is behind the guidelines in here or associated with it, but some poor, pre-medical student of some professor probably drew this, and it really highlights the effect of heart failure and AFib, and that's one of the first triggers and risk factors I like to talk about. So 50% of patients with AFib, when you follow them for years, will manifest with clinical heart failure, the type that ends up in our emergency rooms, that need diuretics, that are actually congestive heart failure. But which comes first? And I think, thanks to modern devices and modern science, we actually have recent data that is quite convincing in the last 2 years. This was a study done by Boston Scientific of 900 patients already with an implanted cardiac device. And they were trying to tell from sinus rhythm to AFib and heart failure, is there a relationship, is there causation, is there a temporal correlation, and can we infer causation of what comes first? Is it heart failure or AFib? This device actually measures a number of variables, right? It can hear what it interprets as S1, S3 heart sounds. It can interpret impedance from the generator itself and look at transthoracic impedance, which is a sign of fluid buildup subcutaneously and interstitially, and look at heart rate and patient activity level, and particularly nocturnal tachypnea, right? We hear about P&D and orthopnea, and the pacemaker can pick up the precursor to that. Most of these patients had the CRT device, which came with this algorithm. And what the authors did was look at the episode of AFib that precedes the heart failure. Or is it the heart failure that precedes the AFib? So let me break this complex chart down here. So right here, we're seeing that, before incident AFib, whether it's 6 hours, 24 hours, there's signs of a cumulative score of worsening congestion. So there's fluid buildup, there's pressure buildup in the heart. S3 seems to be enhanced prior to every AFib episode in these continuous CRT devices that was detecting. You'll notice actually respiratory rate changes significantly. The patient's body, their own physiology knows that something is actually going wrong. And right at the moment of AFib, particularly after 24 hours of AFib onset, if you have a long episode of AFib, respiratory status tend to worsen, but what we notice is that heart failure can follow next, which I will show you on the next slide. But it does seem that subclinical heart failure congestion in a setup, in the wrong setup, precedes the atrial fibrillation. But once the AFib gets worse and worsens the cardiac status, the heart failure follows. So this graph right here shows individuals on the very top who had an AFib episode for 24 hours and following them from that time on for up to over half a year versus individuals on the green bar here no atrial fibrillation, right? They were having their device. Yes, this is a group of patients who was a setup for heart failure. They had CRT device. They have chronic systolic dysfunction, but they did much better compared to those with AFib. So AFib comes right back and worsens the heart failure. And I just want to point out, this is one of the more elegant studies of our modern time, taking advantage of data that's already there and proving the fact that it's both chicken and the egg, the AFib and heart failure. And the authors went on and said, look, NT-proBNP, a marker of congestion, also supports the hypothesis that every stretch, every ounce of extra pressure buildup in the heart and congestion increases risk of AFib. And individuals who have AFib for longer than 24 hours are much more prone to having an ER episode for heart failure, urgent visit, or be admitted for congestive heart failure. So what about if we looked at things forward? What if we did something about it? And this was the RACE 3 trial. I think all of us back in med school or residency or fellowship are reminded of RACE 2. That was the trial that showed how slow should we control the heart rate in the setting of atrial fibrillation. Is there a difference to intensive control? Well, RACE 3, same group of authors, they said, what if we found people who were in kind of, first-time AFib, a mixed group of heart failure with reduced ejection fraction, preserved ejection fraction, and they may be persistent, not long persistent. They may have mostly paroxysmal. And that was the group of people where they said, what if we randomize this 250 patients to aggressive management, right? Afterload reduction, a mineralocorticoid receptor antagonist, as well as statin, which is debatable, and versus just sending them to cardioversion in 3 to 4 weeks. And antiarrhythmic drugs were actually pretty scantily used in this early study. So we can see here on the blue bar, these are the patients that got this targeted therapy. And it wasn't even diuretic targeting. It was just simply treating what you expect for preserved mixed hypertension, metabolic syndrome type of patients. They're probably undertreated with an MRA, which you can argue has a light diuretic effect. And you can see here in the blue bar, the targeted therapy maintains sinus rhythm at 1 year. And actually their burden is about half as much at 1 year compared to individuals who just went off to cardioversion. You let them be. But at 5 years, it is hard on this group of patients to say, look, without better targeting, without better management, if you just let them to your natural course without keeping monitoring, watching their fluid status, there wasn't much of a difference in that aggressive upfront therapy. So you kind of lose the benefit in terms of having another AFib event. And we know from the early Cabana trials, the subgroup analysis showed that individuals with systolic heart failure may be beneficial for ablation, even though Cabana was a net negative trial for outcomes. But this was further consolidated in CASTLE-AF, CASTLE-HTX. This was a study looking at individuals with systolic heart failure. A lot of them were 35% EF or lower. And even that sick of patients who often have persistent AFib, if you were to address rhythm control with ablation versus medications, you actually ended up creating not just, preventing hospitalization, but actually preventing death, mortality. This was an even sicker group, a subgroup, or a separate trial looking at individuals who were nearly on the transplant list or LVAD list, and they were able to stave away transplant in a majority of them, as well as have better survival and reduce hospitalization with ablation for medical therapy. So in systolic dysfunction, in the traditional heart failure, we definitely can see that there is benefit to having rhythm control, and the most effective rhythm control being ablation. Does the type of heart failure matter? More and more we're seeing heart failure with preserved ejection fraction. More and more we're seeing HFpEF, a metabolic disease, a heart in a bad neighborhood. And this is a meta-analysis of all the pooled data of rhythm control, AFib ablation, and the type of heart failure, breaking it down by preserved and reduced systolic function. And we can see here that actually it's durable in people with HFrEF, systolic dysfunction, but not so much in HFpEF, because we know this is a messy neighborhood. These patients do not just have heart disease. They have CKD, they have obesity, metabolic syndrome, fatty liver. Very different group, and probably untreated sleep apnea, which we'll talk about. So not much net benefit for aggressive ablation for heart failure with preserved ejection fraction, but definitely this is a group we should pay attention to and further optimize with rhythm control by ablation. So hypertension, I do not need to spend a lot of time talking to preventive cardiologists and a preventive group about managing hypertension. I think we know that systolic hypertension over a lifetime has many bad ills for the heart, and certainly increase with at a high level, right? Above stage 2, you got a 50% chance of relative increase of developing AFib. Every 10 points higher is another 10 to 11% of incident AFib in a lifetime. So I'm not going to spend too much time talking about hypertension because we know we should treat it and we should counsel our patients on this. And this gets also a class 1 recommendation from our current guidelines. The signal seems to be stronger for ACE inhibitors and ARBs, which we're very familiar with using, as well as spironolactone or mineralocorticoid receptor antagonists. But you can see if you treat hypertension, there's less association with incident AFib, which is pooled across many, many studies, and particularly in those with heart failure, pre-existing episode of heart failure. Sleep apnea and AFib, and I kind of want to spend a little bit of time here. If we all went to Vegas and said, hey, we're going to bet on sleep apnea for every patient who shows up with the first incident AFib, we would win 3 out of 4 times. Now, is it a causative agent or is it a marker of poor health? Well, there are multiple substrates that can serve as AFib, and I do think sleep apnea is both contributory and a marker of bad neighborhood, bad systemic health. So 31% greater recurrence with AFib with untreated sleep apnea, even after ablation. Even with the most aggressive therapy, you cannot prevent it away with just ablation alone. And individuals who are more adherent to actual sleep apnea therapy by CPAP, we found that they are much less likely to recur even after the most aggressive therapy for AFib. So just ablating, just rhythm controlling alone without managing this has a 31% greater risk of recurrence. And what's interesting is they've done experiments in rats, right? Where is the causation statement coming from? During apneic events, and the more you accumulate, there's literal stretching and changes in intrathoracic pressure transduced to the left atrium. It is stretching, it is shrinking, it is stretching. And I believe at least there's some amount of mechanical damage and fibrosis that causes this. And the more episode, they were pretty cruel to these rats. They held their breath for 40 seconds before expiration to generate this intrathoracic pressure change. The more they had, the more the negative atrial remodeling occurred. So we're very familiar with this bottom curve on alcohol and AFib. Alcohol has a J-curve in the population, probably not stratified for socioeconomic status, but we know that some light drinking is associated with overall maybe improvement in cardiovascular outcomes. But in AFib, it's a straight line, and I would like to convince you of that. So alcohol, even a drink a day, is associated with hypertension, atrial scarring, inflammation, rebound hypertension, vagal activation at night. I probably have sleep apnea after 2 glasses of wine. And even binges, right, are the acute trigger. We all learned the holiday heart effect. And this is really proven in an elegant randomized controlled trial where a group of normalish drinkers, right, 14 to 16 average drinks starting off, you randomize them to going down to 2 drinks. That's what they achieved after 6 months, 2 drinks from about 16 drinks on average a week. And this is kind of a 12-ounce beer equivalent. And here the control group just said, hey, do whatever you want. This is a group of patients who already developed paroxysmal AFib. Let's see what happens in a natural experiment. So they measured the burden of AFib and time to first occurrence. And as you can see here, time to recurrence, AFib likes to come back. We know this. Time to occurrence by abstaining from alcohol, going from just above the healthy amount of drinks, 2 drinks on average per day for men, right? They were at 16 or so. Going down to 2 drinks had a significant benefit at preventing the next episode. And furthermore, a significant amount of people in the abstinence group had 0% AFib burden, right? I wouldn't say they cured their AFib, but they definitely slowed the progression. And thus, I think this gets a very strong class 1 recommendation from our societies to say, just cut down on your drinking, even down to 0, there is potential benefit. Smoking, I am not gonna spend too much time on this one. Class 1 recommendation for life to quit smoking. There are so many good reasons to actually quit smoking. And I think smoking is not a direct effect on AFib, but rather through the risk of COPD. Another elegant study in arrhythmia back in 2018, looking at when an individual who is hospitalized or in the ER for COPD exacerbation, within 30 days, their risk of AFib skyrockets. And we can spend all night here debating, is it the albuterol around the clock that they got that was adrenergic stimulation, or is it their lung health and smoking and inflammation of their heart? But I would say every patient should quit smoking, and I don't think I need to spend more time on the 1440 reasons to quit smoking. I don't know if anybody's read this book, but it seems like a lot of reasons, good reasons to quit smoking. So I do want to spend some time on obesity, and I know this is actually a sensitive topic for all of society, right? I think for 20 years now, we moved on a body image positive side, and I think there is benefit to that. But I think we might have been neglecting the metabolic changes underneath and not being clear on how we convey the science to our patients. So obesity, addressing obesity, 10% weight loss is actually a class 1 recommendation in our guidelines, but let me show you why. We know the obesity alone is a 50% increased risk of Afib. We know that every 5 units in BMI is another 10 to 11%, 10 to 13% increase in Afib, is even after ablation. And there's a wonderful study called the Legacy Group. They did a natural experiment, offered pre-Ozempic, this is before we had Ozempic, Wegovy, all these medications, aggressive weight loss, and individuals who followed it, or individuals who did not lose weight, they followed them for 4 years. And this was a beautiful natural experiment because it showed the effect of weight loss on obesity. So in the red line up here, you can see these are individuals who achieved a 10% or greater weight loss. And for many of you know, right, that's what it takes to also regress fatty liver disease in a non-alcoholic or metabolic associated fatty liver disease. And compared to those who had less than 3% or weight gain, actually, the Afib freedom was much higher, not 100%, but much higher chance of you maintaining sinus rhythm about 4, even going on 5 years. And this group of authors even said, what about weight fluctuations, right? People go on diets, people fail all the time. So on the right here, you'll see that individuals who had weight fluctuations actually did worse than individuals who took weight off in a healthy manner and actually maintained the weight off consistently. So the best benefit you're gonna get is to get the weight off and maintain that healthy lifestyle, and that's gonna reduce your chance of Afib. Authors did measure all the inflammatory markers, which are decreased, the lipid volumes, the left atrial volume, the E to E prime ratio. These features of worsening cardiac function, congestion, inflammation all went down, not surprisingly, with addressing obesity, even with lifestyle modifications. So I do want to move on to bariatric surgery, right? Seems aggressive, but I do think it might be a treatment. So bariatric surgery, we know, actually reduces the risk of Afib after ablation. And this is a group that started out at about a 45 to 50 BMI, all underwent bariatric surgery, and versus not. And this is an observational cohort. I know it's not randomized. And when you look at individuals who were not obese, these are individuals with Afib, went in for their bariatric surgery or not. If you had bariatric surgery and on average lost weight, you looked like somebody who underwent ablation if you didn't have obesity, and they were still at a 37 BMI. So a surgical weight loss induced a similar population effect as somebody who underwent ablation with Afib without obesity. Versus if you had obesity, well, the freedom from Afib is quite poor. This is going to be not a healthy journey and a pretty miserable life for our patient if that's not tackled. Like to change gears on caffeine and Afib. For years, we told our patients caffeine, PVCs, caffeine, PACs, heart palpitations, arrhythmias are associated with caffeine. But is atrial arrhythmia, particularly Afib, associated with caffeine, or is caffeine causing it? And one of my favorite trials, I think this came out of UCSF, the iStop trial, basically showed all the patients think they have many triggers for Afib, including alcohol, including caffeine. They took individuals with paroxysmal Afib, told them to put in a journal at what time they did something or ate something or slept funny, and they categorized them by some of these exposures, right? We see down there large meals, not clear signal, but what we can see is consistent here is that caffeine is also not a trigger of Afib or not associated with every episode that they have. And even amongst physicians, right? We are a stressful group. We sleep poorly. We have sleep apnea probably after we drink. Increasing amounts of caffeine, in fact, may have even been associated with less Afib, but certainly do not increase the risk of Afib. So we should not be telling our patients to stop drinking coffee if they have paroxysmal or persistent atrial fibrillation. They may have palpitations from drinking coffee alone, but it is not a causative agent. we are going to get to talk about alcohol, or we already did talk about alcohol, but this just further confirms the fact that our patients should quit drinking if they seek a rhythm control strategy. But this was so strong that our own society said, okay, can we stop telling our patients to quit their coffee? There's no benefit in quitting this to prevent AFib episodes. And here's a pretty unhinged AI photo of what maximum caffeine consumption is. Fish oil and AFib. This is not in our guidelines. This has been experimented. I swear half of our patients are on fish oil or more. Maybe some of us are too. My argument is we should probably eat fish, and I'll demonstrate why. For a while now, there's multiple studies testing different formulations of fish oil. Reduce-It trial, we're all very familiar. The first time that a EPA-based fish oil at a high dose reduced coronary vascular events, but that's not why we're here. What the authors noticed, right, it's buried under there in the discussion and secondary outcomes, is there was a signal of significantly higher AFib in 4 grams a day of icosapent ethyl group, predominantly EPA fish oil. And this is seen in European data, this is published in BMJ, that fish oil supplements may transition people into more episodes of paroxysmal AFib when you look at the whole population. And certainly we shouldn't be telling our patients that fish oil, and here vitamin D, in a randomized fashion, prevents AFib by any means. So I am not saying to stop taking your fish oil. I do think everyone should eat more fish as part of a Mediterranean diet. But we should not tell our patients to use fish oil to try to prevent AFib. And perhaps we should keep an eye on the data and kind of caution them that maybe there's a signal emerging. We often see the very young onset AFib. I mean, every few weeks we'll have somebody 23 years of age, 33 years of age. They have no metabolic risk factors. They were not hospitalized for congestive heart failure, and they show up with AFib. And I put this here because, in large studies, a good amount of, just under 20% of patients have a genetic mutation, a hereditary arrhythmogenic condition, or a cardiomyopathy. And I think this is a nice practice pattern. It's not necessarily a strong recommendations, but getting a good family history, going back to the basics, and actually fishing for if certain patients need genetics testing, need further imaging. I think in our young AFibs, there's a good group of them hiding amongst us that have tight and truncating mutations, as well as myosin heavy chain mutations, the HCMs, the dilated familial cardiomyopathies, as well as the more scary one, the lambda mutation. So it's good to pay attention to this, and I'm sure we will have more data as time goes on. The athlete with AFib. I think many people here are interested in good health. Exercise is a preventative therapy, unlike any other. And we encourage exercise. It says moderate intensity exercise to vigorous. 210 minutes per week is actually good at preventing AFib in the future and probably reducing AFib symptoms by preventing diastolic dysfunction and improving CV health. But there is a little bit of a hint of an association with worsening potential risk for AFib, particularly in males. So this is probably the largest study to characterize this, and this is replicated in many other populations. Yeah, as you know, the United Kingdom has one healthcare system. They got data on everybody. So when Big Brother collected the data together and put them all together, there seems to be a J or U curve association somewhere around 3 to 5,000 mets per minute per week. And as you recall, metabolic activity or met equivalence per minute, this is calculated just by sustaining, say, a 4 mets activity per minute. And at a 5,000 threshold, there was actually an association with increased AFib. And I think all of us either have friends or patients who are endurance athletes at a high altitude with high cardiac flow that their heart has remodeled. They have slight chamber enlargement, increased atrial fibrosis. And I think there is good data to say on the extreme end of exercise, you might actually put yourself at risk, even though you are treating the rest of the body in a healthy way. So I think the cutoff is emerging that it's really vigorous exercise. And I try to equate to a sport that I really enjoy doing, snowboarding. That's about 14 hours of nonstop downhill powder snowboarding per week. If you're sustaining that, that's about 5,000 mets per week exercise, which is associated with about a 12% relative increase in atrial fibrillation. And there are many mechanisms here, right? A lot of it we already talked about. Nocturnal vagal stimuli, the changes in pressure, the stretch of the atria and contraction, the increased flow. You have a lot of other features that we don't fully understand. Is it healthy fibrosis? Is it harmful fibrosis? But we see the fibrosis in the atria. And there is such a thing as a vagally stimulated AFib. So all these risk factors, I think, just by chance, set the person up wrong. Despite them asking you, I'm living a healthy life, they're at a risk for AFib on the extreme end of exercise. And we see that in Utah quite a bit. The last half of my talk, I want to switch gears and talk about anticoagulation. There's a lot of new data developing. There's some controversies. They may not all have been cleared up, but we all start here, right? Class 1 recommendation to say, let's make sure we understand, is this patient at intermediate or high risk? With a CHA2DS2-VASc 2 in men and CHA2DS2-VASc 3 in women being a high enough risk to say confidently, let's start anticoagulation. And the Atria score, which I'm familiar with but do not use, is also another validated method. So I think this is the first time in formal guidelines where we said direct oral anticoagulants, what used to be called NOACs, novel oral anticoagulants, are preferred over warfarin. And there's many reasons that I will demonstrate. As you recall, and what we pimp our med students on, there's two pathways, more tissue injury, more vascular pathway, intrinsic pathway. And our drugs, apixaban, edoxaban, rivaroxaban, are factor X inhibitors, and dabigatran being a direct thrombin inhibitor. And what we haven't talked about here is the emergence of factor XI inhibitors, which is yet to be proven. So these are the classic studies that we are all very familiar with. You have Rocket AF right there, and Aristotle on the left here, that showed that rivaroxaban versus warfarin not only is non-inferior, but actually had decreases risk of bleeding and intracranial hemorrhage, and you had less embolic risk. And we know this, warfarin can be finicky. Much of our patients are out of their INR time, and that is probably why we are seeing both embolic and hemorrhagic benefits in DOAC, which is a much more steady dose. So dabigatran, similarly, demonstrated at 150 milligrams twice a day, improved findings in edoxaban right there. So just presenting to you the data that why there's such a strong recommendation for the novel or direct oral anticoagulants over warfarin. Briefly leave this table up. There are dosing nuances. I wanted to highlight, as a reminder, apixaban. If you have 2 out of the 3 over 80 years of age, creatinine over 1.5, weight under 60 are little old ladies that are growing old, they should be dose reduced if you have 2 of the 3 factors. If you're on near dialysis but not on dialysis with a GFR less than 15, you should probably go to 2.5 BID. Dabigatran, dose reduction for renal function, 30 to 50, you go to 75 BID. Edoxaban, 60 daily normally, you go down to 30 milligrams daily if you have a GFR of 15 to 50. Rivaroxaban, from 30 to 50, you do 15, but otherwise it's 20 milligrams a day, right? Dose reduction, when there's no cause for this, does not have proven benefit in preventing for stroke or systemic embolism. And as you recall, in the Rocket AF trial, you want to avoid probably using rivaroxaban in those who are in that stage 4, stage 5 renal dysfunction group. And I also wanted to talk about aspirin. I think in the recent years, aspirin, a long time, is a preventative drug. But for primary prevention, we know that for the population for cardiovascular disease, it's out. There's still kind of this old thing dragging on about, well, you know, aspirin's safer than Eliquis, or at least they're on something, or aspirin is safer than Xarelto, at least they are on something. And we know that aspirin has pretty poor systemic embolism protection, but I want to prove to you that actually aspirin is also pretty dangerous. So our guidelines, for the right reasons, say that in individuals who are candidates for anticoagulation, they are candidates, we should not use antiplatelet therapy, aspirin or clopidogrel, as an alternative, right, to reduce stroke risk. There's almost no benefit based on how clots form in the left atrium. In individuals without risk factor for stroke, even if they're in that gray zone of CHA2DS2-VASc 1 or 2, that is not the right patient for aspirin either, because you're increasing harm. And this is shown initially in the Abros trial. They took 5,000-something patients who had atrial fibrillation, and some clinician out there, physician out there said, hey, you're too risky for warfarin. You can't do warfarin. You eat too much fluctuating leafy greens. And they were randomized to aspirin 81 to 324 one day. Most of them were on 81, I think, and then 5 milligram twice a day for apixaban. And what we can see is apixaban over time certainly has much significant better protection against stroke. But what is buried in the study is that major bleeding actually looked about the same, that your aspirin 81 to 324 to 325 has the same amount of hemorrhage. And what's even more frightening is the two groups. An aspirin 81 had a similar risk of intracranial bleeding compared to apixaban, right? The worst feared consequence, potentially fatal consequence of any antiplatelet or anticoagulation. So I pose to you, is aspirin actually all that safe? I don't think so. The risk of bleeding, I'm putting this here because we have 3 calculators. You know, in our guidelines, there's not a specific saying of using which calculator, and a lot of these, if I pointed out to the C statistic, their ability to predict for bleeding coming up, it is hard to predict bleeding within a year, 2 years, or 3 years. This is barely a little bit over a coin flip, right? All these scores look about the same in their performance. As you remember, 0.5 being a coin flip, 1.0 is the perfect test with perfect sensitivity, specificity. So I have not found this to be particularly useful, but sometimes I do use the Has-Bled score to try to guide my risk-benefit discussions. Now, what about the CHADS-VASC of 1 in men or 2 in women? We call these patients intermediate risk. They're under 2% per year of stroke from Afib. Well, there are risk enhancers, and our guidelines point to that. If they have renal disease, that's somewhat significant. If they have a severely enlarged left atrial volume, if they're proteinuric, which is a prothrombotic condition, or if they have HCM, especially hypertrophic cardiomyopathy, this is a group you must anticoagulate, even if they have maybe 6 hours, 24 hours of Afib and a relatively low CHADS-VASC without any risk factors. So I think this points out to the fact that it doesn't just stop at the CHADS-VASC or Atria score, but we should try to understand the individualized risk with these risk enhancers. Okay, now the hottest topic recently is how much Afib is Afib that we should anticoagulate. So this started a while back. There was a trial called the Loop study that said, what if we just put loop recorders? That's so good, 2 years. We can pick up Afib episodes of 6 minutes, 6 hours, 24 hours. And I think most of us, according to the science, would anticoagulate probably for 24 hours. Most of us probably would consider it also for 6 to 24 hours, but even short episodes. So the study actually randomized the patients on, if you detected Afib with a loop recorder, you're going to be either in kind of an aspirin or a apixaban arm. And in this group, it was difficult to show even any benefit on loop recorded Afib because the majority of these patients actually had very infrequent Afib, and we're going to dive into the data on that. So a while back, there was a graphic on, well, we have these other trials called the Artesia and NOAA, which are now published. They will answer the question for us. For Afib of 6 minutes to 5.5 hours, should we just keep observing? Is that an innocent bystander? Especially for individuals with high CHADS-VASC, we're getting worried at 2 to 3 for men and women. You know, maybe there's a gray zone here from 1 to 2. Maybe we can watch and wait and remonitor. And now the studies have been published. So this is Artesia. This was a randomized control trial, 4,000 patients, mean age of 76, so an older group, right, who also have bleeding risk as they age. The majority of these episodes, Afib that was picked up on devices. Artesia picked up device-based Afib. They all had mostly pacemakers, some ICDs, and specifically categorized Afib, that 6-minute to 24-hour, and randomized people to apixaban, and I say placebo, but it's actually aspirin. So you can see that apixaban had a reduction in stroke. We've seen this chart multiple times in other studies, and aspirin had an increased risk of stroke and systemic embolism. But over here, apixaban had almost double the bleeding risk, the event bleeding, compared to aspirin. And even though they were kind of similar in the fatal events, I don't think this was powered to detect all the bleeding. It was not followed up. I think there was a lot of loss to follow-up across the 6 years. It's kind of an even trade-off. Some would argue a crippling stroke is much more than a hemorrhage that ends your life, but I still think the truth is still somewhere in between, and this is a population that we should be careful for and really employ shared decision-making. A similar study was done with edoxaban, also on device picked up atrial arrhythmias, particularly Afib. And it was difficult to actually show any net benefit for individuals randomized to edoxaban. And it really, did not result in a composite outcome difference. So in short Afib episodes, kind of in that 6-minute, up to 6 hours, maybe up to 24 hours. There's maybe benefit, especially as the longer the Afib episodes go, but it is hard to justify wholesale to every single individual without discussing the risk benefits and the trade-off for anticoagulation. Rivaroxaban, years ago, was tested in the Navigate ESSIS trial, and this was also a study that said, hey, what if we'd looked for Afib that didn't exist? Patients who are at high risk at a certain age for Afib, let's just treat those with strokes of undetermined significance. If it looked like an embolic stroke, let's empirically give them a DOAC. And this trial did not end up very well either. These are patients who have not had Afib yet, but thought to be at risk for Afib due to age and thought their stroke could have been cardioembolic. Rivaroxaban, this trial was actually terminated early because rivaroxaban showed significant harm for major bleed event over aspirin for individuals without Afib and a stroke of undetermined source. And this is a lot of our patients, a lot of the consults that we see. And I highlighted in the 2 red boxes, you have, the font's a little bit small, but here we're showing that major bleeding was significantly increased, 2.7 hazard ratio of major bleeding and a significant increase, 4-folds, of intracranial hemorrhage on rivaroxaban versus aspirin. Well, even more refined. So in the prior study, there was a secondary analysis. The authors said, hey, maybe we didn't choose our patients correctly. What about individuals who are at risk for Afib, moderate to severe left atrial enlargement? There was a signal that they may have benefited from initiating anticoagulation by rivaroxaban. And so the Arcadia trial attempted to do this, to kind of tease this out. They chose patients who had left atrial dimensions that were large, NT-proBNP that were big, though I would argue, as any of you that do imaging, these are still not direct markers of atrial myopathy. These are patients who also had cryptogenic stroke and of unknown cause, and they have not had Afib identified. And individuals were randomized to, again, aspirin and a DOAC, in this case, apixaban. They were only followed for 2 years, and what we found is that in individuals who do not know have clinical Afib yet, if you anticoagulated them, you're not really doing much compared to aspirin. And these are an older group, so I understand that sometimes other mortalities compete, but you're not preventing more strokes by empirically starting this. It is not a preventative therapy for those with cryptogenic strokes, embolic strokes, that you think they may have Afib but have not detected it yet. But I put the slide up here again because I think aspirin is probably poison candy in the wrong population. In this study, it was discovered that you did not have any intracranial hemorrhage with the apixaban group, but you had 7 in the aspirin group. So again, there is a role for aspirin, but we should be careful. And I don't think it's a good treatment for Afib, and it potentially has more hemorrhagic risk than we would think. These are some of the common scenarios we come across. For coronary artery disease, particularly after PCI, depends on the will of our interventionalist, but often we do 1 week, some people not even any, of triple therapy, an anticoagulant if they have an indication for Afib, along with their dual antiplatelet therapy. If they got a fresh stent, you may do it for a week or a month, but you should retreat to the P2Y inhibitor and your anticoagulation of choice, whether it be rivaroxaban, edoxaban, apixaban. And then you can continue with anticoagulant alone. It seems to have both coronary and systemic embolism protection. And you do not need to have antiplatelet after the first 6 months to a year, depending on the setting the stent was placed. We're having a lot of patients getting TAVR valves, bioprosthetic TAVR aortic valves. First, talk to your TAVR person first to make sure you get their blessing, but often you can just go to DOAC from the beginning. There's many practices, many hospitals that are doing this, justified by data. And sometimes you can just go with aspirin anticoagulant for 1 to 3 months, and then you can be with your DOAC, be with your anticoagulant choice alone. Mechanical heart valves, we don't mess with DOACs here, right? Many studies have been done on this, small trials, all terminated for harm early on. So different INR targets, do not use DOAC, particularly for that mechanical mitral valve with a higher INR target. I like to conclude and say Afib is common. This is an obvious statement, and it goes more common as time goes on. I think I now quote the patients, depending on men and women, probably 1 in 7, 1 in 8 of us will get it in a lifetime because we are living longer, which is not a bad thing. But I think we need to address, there's a subgroup of population that are getting unhealthier. We're seeing metabolic disease ravage through our population. And I think beyond just going through directly to cardioversion, going through directly to ablation, which are important features in treating AFib, you gotta attack the risk factors. It's not just prevention, it is treatment. And I highlighted here, particularly alcohol, heart failure, volume management, obesity, really addressing those directly can make somebody's life a very different trajectory down the line. DOAC is preferred over warfarin, no matter what the insurance companies want us to think. And particularly for those with the CHA2DS2 in men or women, because sex gives them that extra point, this is a clear indication. We should have no qualms about this, and we should not use aspirin. And I think aspirin is probably more harmful than we think. And we've seen that in the primary prevention coronary disease world, and I think we're seeing that in our AFib data as we collect more. AFib more than 6 minutes, but less than 6 hours to 24 hours, it's still a gray zone. Just this week, there was a subgroup analysis of that NOAA trial, that Artesia trial, that showed perhaps maybe the differentiator is a CHA2DS2 group of 5 or higher, 4 or 5 or higher. You may consider, look, this is a high-risk person, even if their AFib is minor in duration, let's consider treating it because they may derive net benefit. But that's a subgroup analysis, and we know how those can get tricky. So more to come, more data that needs to be done. And I think this is a reasonable transition point before I go to Dr. Ranjan. I think all of us remember the Affirm trial, or in the early 2000s, we said rate and rhythm control were equal in outcomes, in mortality. And the fonts in New England Journal have changed, and so has the data and the science in treating AFib. So I'm going to pause for some questions, concerns. If you're offended or want to comment on the memes, I'm happy to answer those as well. But I thank you for all your attention. I know it's heavy after dinner, and thank you for being here. Question, sir.
Triglyceridemia, and you have them on Visipa, and then they develop AFib. Are you stopping the Visipa?
You know, I guess it depends on if you're the camp, which believe that the control group of Visipa, the mineral oil, was not harmful or not, right? If we dive back into Visipa for a brief moment, icosapent ethyl, the control arm in that trial, right, in Reduce It, was mineral oil, which some people said, look, there was a trend towards unfavorable HDL and LDL and triglyceride changes in a control arm. So was the placebo actually a placebo or potentially a harmful thing? If we get our minds past that, and if we truly believe it was an honest control group, then you and I both know that individuals with cardiovascular events in general have all the risk factors for AFib or heart failure. They start overlapping after years and decades. It depends on their burden of AFib. It depends on their willingness for other treatment. I may not actually stop it. And again, this depends on you believing that Visipa truly has an effect, which has only been seen in one randomized controlled trial. So I'm sorry I dodged your question a little bit, but I'm giving an honest answer in the sense that I think there's still question on, can we replicate this? Is Visipa 25% relative risk reduction of future CAD, is that going to be replicable? And so that is a convoluted answer to your question, sir. Sir.
Yeah, any adverse atrial fib burden in Lidoco-2 with the use of colchicine?
Yes.
Or was it beneficial?
You know, I don't recall AFib showing up there. I do remember, again, not a ding on fish oils, but I do remember a trial, ISIS-2, the Japanese trial, right, that looked at kind of an EPA-DHA mix, and I may be quoting the name wrong, but they also had a trend and signal of increased AFib. I don't know, I think Lidoco actually may have had a signal, but I can't actually confirm off the top of my head right now.
It would be interesting to know whether using an anti-inflammatory would modify the course of AFib development.
Right, though I sense we're kind of the common believers here that the inflammation pathway has been neglected a lot in direct both medical treatment on top of lifestyle changes. And I agree with you, your sentiment in general, and going towards that.
Hey there, I think you did an excellent talk, by the way, first of all. My question is, with the Galileo trial and rivaroxaban post-TAVR, you said earlier that in TAVR patients use rivaroxaban. I know that the Galileo trial is a prophylactic trial with rivaroxaban. How should we navigate that question?
I think what I found in the real world is that it depends on the structural cardiologist and interventionalist of choice. You know, for some of these patients, we end up doing single antiplatelet with anticoagulation, and then we go on anticoagulation because there is conflicting data, both on, you know, factor 10A inhibitors. Is it potentially trending towards harm and more valve failure or microthrombosis? So I think that one, I do leave it up to the structural cardiologist, but if there's any question to it, I end up for that first 3 months just giving them the antiplatelet therapy on top of it, even though we know the hemorrhage risk is much higher. But I tend to be comfortable with DOACs long term, and that's been our structural group as well here as a monotherapy. Hey there. Yeah, so I actually, you know, there's so much to talk about AFib, but I did not put a slide for that transition. I agree, I know the study you're speaking of, that perhaps people who had stable INR ranges, and I think that is a group of people where their time in INR was actually doing pretty well. In elderly frail, I do not switch people, all of them, off of warfarin, unless there's an additional reason, right? Rivaroxaban is once a day, you don't have to worry about it. Same with the doxaban. Or if they had potentially other, you know, bleeding risks, other bleeding diathesis events in the past, I may just choose this because we know still net total, all comers, DOACs have less hemorrhage risk, major hemorrhage risk, especially intracranial. But the switch, you know, for our patients that have been long stable on warfarin, I don't think it's justified to say we must switch. We should not make a strong recommendation to switch them, especially if they're content and using devices like point-of-care INR that's not a burden on their lives. All right. I'm going to hand over the microphone to Dr. Ranjan, who's the actual ablationist. Thanks again, everyone.
Thanks, Libo. That was great. If only most patients followed your recommendations, my job would be a lot easier in terms of seeing less AFib patients, and maybe the ablation outcomes would be better too. So hopefully I convince you of some of that. But I am an EP physician and obviously do ablation. So I will take you through some of that data and where the field stands today, and hopefully convince you that we have come a long way from the days of Affirm in terms of ablation being a very useful therapy to think about when patients come with AFib. Here are my disclosures. I do a significant amount of research. We have a group that looks all the way from mechanisms of AFib to therapies, and I'll get to that a little bit at the end. So I'm hoping to cover a few topics, namely ablations, look at some of the underlying data as the field has evolved over the years. There's lots of excitement in the field about pulse field ablation. I'll sort of briefly touch on that. At the end of the day, a lot of it comes to selecting the right patient, as with a lot of therapies that we have to offer to our patients, and briefly talk about left atrial appendage occlusion. It has become a popular topic. Let me start with a case. This is a 66-year-old male with hypertension, BMI of 28, with symptomatic paroxysmal AFib. When he has AFib, he's quite symptomatic and is forced to stop doing what he's doing. And the episodes that he has, on average, last twice a month from 2 to 6 hours. He's already on an ARB, beta blockers, and oral anticoagulation. Echo shows normal LV function, his mild LVH, normal LA size. He does get a monitor, and it shows about 4% AFib burden with average heart rate, not hear rate, of 98 when he's in atrial fibrillation. So the question is, what do we do with this gentleman? One option is continue current course. He's quite symptomatic, so most of you would agree that's probably not the best approach. You can increase beta blockers, and that is helpful for some patients who have very high heart rate dependent symptoms. And when you do some rate control for a lot of patients, It makes their AFib symptoms much more tolerable, especially on the elderly who are not very active. But for somebody who's very active, it does not go very far, and despite sort of blunting their high heart rate response, they continue to be symptomatic. There is this notion of pill in a pocket antiarrhythmic for patients who have rare episodes of AFib, but for somebody like him who's having it twice a month, I think probably would be stretched, because obviously you take the pill after you had the AFib and it's really not helping. So you could sort of put him on a class 1C and increase the beta blocker is one approach, which would be very reasonable on somebody. And the other approach would be to take him for an ablation. We were obviously skeptical of that a long time ago, but the guidelines have changed as the field has evolved, and this is the same guideline that Libo was referring to. And now in this, if you look at recommendations for AFib catheter ablation, class 1 recommendation now is in select patients, generally younger with few comorbidities with symptomatic paroxysmal AFib in whom rhythm control is desired, catheter ablation is useful as first-line therapy to improve symptoms and reduce progression to persistent AFib. So it's very reasonable in obviously the right patient set to think of ablation as first line before you give them, even consider antiarrhythmics for them. And that obviously is a big change from where we were even 5-10 years ago, where we sort of tended to use antiarrhythmics first, and if that failed, only then talked about ablation. And I'll share some of that, some more data as to where that is coming from. And I think that has a lot to do with how we have gotten better at doing the ablations. The risk profile has gotten much better over the years, and the outcomes have definitely gotten better, especially for paroxysmal AFib. Persistent AFib is a little bit of a different ballgame, and we'll sort of allude to that a little bit as I talk more about the ablation. So what about long-term benefit beyond just symptoms? And we have started to see some data even alluding to that, and that is, this is the East AFNet trial, which was a multi-center randomized trial comparing early rhythm control with usual care in patients with early AFib and cardiovascular condition. For rhythm control, they had options of using antiarrhythmic and ablation. And they used a composite endpoint of rate of death from cardiovascular causes and cardiovascular complications, including hospitalizations. So here is about 2,000 patients who were included in the study. And on the left are the people assigned to rhythm control, and the right sort of usual care. And you can see the vast majority of them got antiarrhythmics. That was sort of the initial starting point, and over the 2-year period, a good number of them had already converted to ablation, which is shown in blue at the very bottom of those bars. But initially, a lot of them had antiarrhythmics in the beginning. In the control arm, the usual care arm, obviously they were not assigned to rhythm control, so very few had or antiarrhythmics or ablation, but even in that group, you can see that there's a small group that transitioned over, presumably because they had symptoms. And here is the data. I mean, this is primary outcome, which was a composite of death from cardiovascular causes, stroke or hospitalization with worsening of heart failure or ACS. And you can see early rhythm control was more effective in this group. The point of this slide I've just put in to show this is sort of very typical of the patient population we see. Average age about 70, BMI was about 30, and CHA2DS2-VASc score about 3.5. So very sort of typical patient population with early stages of AFib, and aggressive control showed composite benefit. So starting to show some data that early aggressive intervention is good. What kind of therapy you take, obviously, is a discussion to be had between the patient and you, and ablation very much fits into that discussion. And this is sort of looking at the data a little bit more depth, and early rhythm control, you can see about 249 out of 6,000 who had an event in rhythm control versus about 316 usual care, making it having an effective treatment for that group. Safety outcome, again, obviously we worry about putting patients on antiarrhythmic versus ablation, and here it was very similar in the two groups with no significant difference in terms of the total composite safety outcome, which had death and stroke, as well as sort of severe adverse events. And we're not just talking about minor things like bleeding, like hematoma at the site of ablation site and stuff. That obviously was higher in the group that underwent an invasive procedure, but that was all sort of temporary and easily addressed. What about early intervention, and how does it affect progression of atrial fibrillation? And that has been again looked at. This was again a randomized study where people had aggressive ablation / antiarrhythmic, and they looked at progression of Afib. And this was 255 patients who underwent ablation versus antiarrhythmics. And the rate of progression in the group, in the ablation group, was actually better or lower at 2.5% as opposed to antiarrhythmic drug. And I think that gets to the point that antiarrhythmics are useful to use in terms of controlling symptoms, but they're not as effective as an ablation. Given there is an increased cost initially in terms of obviously being invasive procedures, so having some risks, but the outcomes are better long-term, and the patient with RF ablation were 10 times less likely to develop persistent Afib atrial tach as compared to the other group. So again, making an argument for early aggressive intervention, and this is just showing the cumulative ablation versus antiarrhythmic treatment in terms of patients progressing to atrial fibrillation, and you can see shown in red is the ablation group that had much lower progression to Afib. Intention to treat versus as treated, and you can see obviously there is some crossover in these patients, and as treated gets even better. So based on this, we talked about how ablation has made it to Class 1 guideline or recommendation for thinking about ablation. Libo talked about what about patients with reduced LV function and in whom data is just as clear, if not more so, that you should at least be aggressive about thinking about ablation for them in terms of improving outcomes over time, and ablation should very much be part of that discussion treating for these patients. And again, it's Class 1 that in patients with reduced LV function and persistent or high burden Afib, a trial of rhythm control should be recommended to evaluate whether Afib is contributing to reduced LV function. And this is beyond just people who have very obvious tachycardia-induced cardiomyopathy. This is more so in terms of the rhythm itself, the irregularity of it leading to worsening heart failure. And this is sort of, again, from the guideline where you have heart failure. We'll sort of talk about that next. But even if you don't have heart failure, there has to be a shared decision-making of aggressive rhythm control. Antiarrhythmics are fine as starting point, but catheter ablation are very much a Class 1 indication as first-line therapy for select patients without having significant comorbidities, as well as patient preference. And this is sort of the flow chart. And again, obviously, it's a discussion to be had where you look at patient choice factors in, where patient prefer rate control versus rhythm control. age in older patients, you would sort of think about rate control versus younger who would want rhythm control. History of AFib, if they've had long-standing history of AFib, you think about rate control versus rhythm control, as well as, again, now symptoms. So all that has to be factored into how you sort of perceive what to do. Rate control in AF, if they're easily controlled, you could obviously talk about having rate control as a strategy. Left atrial size, that's obviously something that I evaluate patients, whether I commit them to an Afib ablation, as well as valvular disease and whatnot. So it becomes a discussion with patients as we sort of gel in terms of what the best strategy is. For patients with heart failure, obviously we optimize their heart failure treatment, and everything, including rate control versus cardioversion, is part of your repertoire, at least in the beginning when you start seeing these patients. But once you've sort of stabilized them, got them to goal-directed medical therapy, if they're still having AFib and symptoms and heart failure, where do you go from that? And that's, again, the point of this is Afib ablation, especially with reduced ejection fraction, is very much something to consider, and class 1 based on current guidelines. Obviously, we have come a long way in terms of how we are dealing with these patients, with Afib ablation becoming more and more into the picture. This is to talk a little bit about the success and complications from Afib ablation. Pulmonary vein isolation is very much the main treatment strategy for patients with atrial fibrillation. That really forms the cornerstone. There are different technologies or energies that we use for ablation, be it cryo, be it RF, and I'll touch to or allude to the pulmonary, the PFA technology that's coming up. This is a study done looking at cryo versus antiarrhythmic treatment in patients in early AF. And on the left is the panel showing the Kaplan-Meier curve. This is in patients who had a loop recorder, and even 30 seconds of Afib was considered a failure. There's lots of discussion in the world of EP about how meaningful that is, and most of you will agree that a 30-second episode of Afib in somebody who was having hours of Afib much frequently, as opposed to one 30-second episode, clinically would be very much acceptable, and you would consider that success. But at least for the purposes of studies, that is the definition we use. And based on that definition and having a loop recorder, the ablation success was about 60-65%, as opposed to antiarrhythmic, which was close to 30%. On the right-hand panel is just to show you the Afib burden. So I want you to look at that and see what low burdens we are talking about. The Afib ablation group had 0.1, 0.2% of Afib burden, as opposed to antiarrhythmic, which was also much significantly different, but again, we're talking about low 2% Afib burden. Point being, the ablation is better. The antiarrhythmics can also be effective, but obviously not as much in terms of reducing it. But as I showed you earlier, how sort of getting them into rhythm helps with controlling progression of Afib over time. So early aggressive treatment should definitely be part of your playbook as you see these patients with atrial fibrillation. I alluded to persistent. That's a little bit of a different ballgame. Success is higher for paroxysmal, not as good for persistent Afibs, and that sort of is a topic of big discussion that we sort of talk a lot in the EP world about how to do or how to handle it. And there's lots of thoughts, and people do different things, but unfortunately not unified opinion as to what the approach should be. Alluded to a little bit to about 30 seconds, and that's sort of very much sort of relevant to clinical trials and studies, a very different ballgame when it comes to sort of clinical effectiveness of that approach. I talk about the ablation approach to take, and at minimum, pulmonary vein isolation is sort of the go-to strategy for Afib ablation, especially very effective for paroxysmal, but what to do beyond that is unclear for persistent. People have tried different mechanisms of targeting triggers, rotors, posterior wall ablation, fractionated atrial electrograms and whatnot. None of that have borne out in large studies. We have sort of some thoughts over it, and I'm happy to have more discussion if somebody is really interested, but it's obviously a big topic of discussion. I quickly wanted to touch base on the complications, as that was sort of the one thing holding back ablation recommendation, at least initially in the days of Affirm, when the complication rate used to be higher, leading to washout in terms of rhythm versus rate control. And these are sort of obviously a long list of things that can happen. And these are obviously, this is put together in the guidelines, so it's going back some years looking at it. We have gotten better even from that in terms of how good we have gotten with all the newer technology and experience in AFib. But I wanted to highlight a few of those. Left atrial esophageal fistula / esophageal injury, obviously a dreaded complication, continues to be a concern when we use RF versus cryo. And this is important, and I bring it up in the world of PFA, pulse field ablation, which is coming up as being much safer and not having esophageal injury issues. Cardiac perforation and whatnot, obviously when we go transseptal and you're ablating in the atrium, you got to be careful about that. Stroke risk, now we are ablating patients on complete anticoagulation, and that has helped decrease those things. PV stenosis, now that it's well recognized and we are aware of how and where to ablate, those numbers are really much, much lower in terms of the general population if you look at recent times. Phrenic nerve issues continue to be an issue, more so with balloon-based approach as opposed to RF-based approach. Vascular complications, mostly hematoma that happens because of large catheter sheets is an issue, but even for that we have gotten a lot better using closure devices. And in most places, AFib ablation has become sort of a single outpatient procedure, single day outpatient procedure, where we are sending patients home the vast majority of time, same day, and they're doing quite well. I did say I was going to talk a little bit about pulse field ablation, which is sort of the new and upcoming thing. There's lots of excitement in our field about it, and the technology is electroporation. Any one of you who did any sort of virus transfection of cells would know all about electroporation, and that's the technology here. If we give a high voltage field across the cells have pores in them, and if you give high enough, then those cells die over time, and that sort of is the basis for this. The pulse field, the gradient that you need to cause cell death is very different from different kinds of tissue. As it happens, cardiac tissue is much more sensitive, and it's much more sparing for nerves and esophagus, so it works in our favor. I did learn as I was looking a little bit more about pulse field, and you guys might find it interesting, pulse field ablation or such electroporation approach has been used for a long time in agriculture. Our fries go through some electroporation treatment, supposedly, that makes it crispier. I did not know that till long ago, as I sort of started delving a little bit more into electroporation. And as I said, the big attraction is that it's much safer, so you don't have to worry about sort of causing the side effect, the complications, and it's also shown that it doesn't cause pulmonary vein stenosis. Interestingly, there is obviously a rush to get this technology to market. Studies have been done, but they've all been non-inferiority studies. So that's where sort of I think the Achilles heel is for our field in terms of showing whether it's better or not, and that part has not been done. Just based on doing non-inferiority and safety studies, this technology has already been approved. There has been sort of wide adaptation of it. And one thing that it has done is it has reduced the procedure time significantly. I don't know how much you know of your EP colleagues, but centers that have adopted pulse field have sort of doubled the number of ablations that they're doing in single day on this technology. And the left atrial dwell time has gone down to somewhere like half an hour for lots of these centers. Essentially, you put in the catheter, you get the catheter to the pulmonary veins, ostium, you give the treatment, which takes only a few seconds, You move your catheter around to make sure there's isolation, and then you're done. So if you've gotten more efficient in terms of room turnover and left atrial access, the AFib ablation time has gone down significantly, making it very attractive. I joke with my colleagues that we'll very soon become sort of dermatologists taking care of pimples and whatnot in terms of the throughput that is happening. But yeah, something to be on the lookout for as we evolve how we do these things. This is just details of this particular study where they did pulse field ablation. And as I said, the point was just to show non-inferiority, and they showed it, that pulse field was very similar in terms of comparing with current thermal ablation, and based on this has been approved. The primary and secondary endpoints, they were all very similar. If you just look at the treatment success, as I said, it met their non-inferiority, not superiority, and that was enough to get ablation. Getting to the end of my talk, so thank you for bearing with me, but I just wanted to conclude on a couple of cases. 76-year-old male with CAD, hypertension, BMI of 27, symptomatic persistent AFib, comes to see you in clinic. AFib was diagnosed during colonoscopy. He says he's more tired than he used to be. He's already on medications for his blood pressure. He's on oral anticoagulation. Again, echo shows normal LV, mild LVH, mildly enlarged left atrium. EKG in clinic shows AFib at a rate of 84. What are you going to do for him? You could continue with rate control strategy, one possibility, but he is symptomatic, in meaning that he's more tired. And that sort of is the most common complaint I get in a lot of these patients who've had AFib for some time, who are adequately rate controlled and just said, yes, I just don't have the same energy. You could add more rate control. I'm not sure how helpful that would be. You could cardiovert them, get them into sinus rhythm, and assess symptoms. Obviously, you want them to be on blood thinners and before you do that. And that's sort of a common approach I take for a lot of my patients in whom it's not clear if they have symptoms before I sort of take them to ablation. And a good number of patients, cardioverting them really brings out this symptom. They can contrast with their sinus rhythm. And obviously, if they're symptomatic, I take them to the next step of aggressive rhythm control. You can start antiarrhythmics right away. Is an approach to take, especially depending on somebody, how long they've been in atrial fibrillation and whatnot, if you think cardioversion will not be effective. And ablation in general, I sort of keep it based on assessment of symptoms if it's going to make a difference for these patients. Another case, 72-year-old female, CAD, BMI of 27, symptomatic persistent AFib, comes to see you in clinic. AFib was diagnosed, went to see her primary care after developing dyspnea on exertion, much more tired than she used to be. PCP did an EKG, showed AFib of 125 beats per minute. She was started on beta blockers, oral anticoagulation, echo shows EF of 40%, moderately enlarged LA size. You want to have as aggressive rate control as quickly as possible. You could cardiovert again after a month of anticoagulation, assess symptoms. You could start antiarrhythmics and cardiovert. Again, there's no right or wrong answer here. A lot of it sort of gets to style. But at least in these patients, you really want to be aggressive in terms of controlling the rate at minimum. Ideally, you want to get this person out of AFib as quickly as possible, be it cardioversion, antiarrhythmics, and then think about ablation. At least that's the approach I would take. Especially as in our practice, as Libo knows well, we're booked out a few months for AFib ablation. I did mention that I was going to talk about left atrial appendage occlusion. It's becoming popular in a lot of centers. We believe it has a role to play for sure in patients, especially those who cannot tolerate blood thinners. But at least we are not sold to the point of saying you need to have this as a replacement for people who could tolerate blood thinners. This is at least the recommendation, which is from the official guidelines, class 2A for patients with CHA2DS2-VASc of greater than or equal to 2 and contraindication to long-term oral anticoagulation. Percutaneous appendage occlusion is reasonable, class 2A, and in patients with moderate to high risk of stroke and high risk of major bleeding, reasonable alternative to oral anticoagulation is class 2B. I just want to share one study, which was not randomized trial, but this is just looking at real-world experience in patients who had Watchman. They did have 2 years of outcome. This was in patients who had high risk of bleeding or they had bleeding episode. And they had the appendage occluded device. 72% in this group was unsuitable for oral anticoagulation, mostly because they have had prior bleeding episode. And they obviously had, it was a very broad range of patients who were included in this Watchman study. And what they found was that it really reduced their ischemic stroke rate compared to if they were not going to be treated with an appendage occluder because they could not tolerate blood thinners. A significant reduction in terms of stroke as well as major bleeding. So good option for patients who cannot tolerate blood thinners because of significant risk of bleeding or they were having active bleeding. But a word of caution before we transition to putting this willy-nilly in patients who do not have high risk of bleeding. And what I wanted to show you was this, not this, but this particular slide, that in 34 patients, which was 4% in this group, had device thrombus seen on their Watchman device. So as we are transitioning, and there's lots of aggressive push to put this in patients who just don't want to be on blood thinner despite not having any contraindication, that you are going to end up with this problem with good number of them having thrombus on them, and now you're going to be putting them on blood thinners because of this. So just a word of caution as we think about referring these patients who have not failed anticoagulation treatment before you think about Watchman. I did say that I do spend a lot of time doing research, so I'm just going to share just quick slides in terms of what the future could be for some of our EP patients. This is using computational modeling to guide ablation. This is not Afib, this is atypical atrial flutter, which is a pain for us to deal with once we've had ablation and whatnot. So what approach that we are using, some of you might know at University of Utah, we're very good at doing high-quality MRIs, and there's been known to do atrial sort of scar-based assessment in MRI. So we've used MRI to make mathematical models of where the atrial flutter circuits are. And this is just an example of a patient, not that you look at these maps all the time, but in the upper left-hand corner is a map that I made of a patient in Afib ablation. And what I'm trying to show you by that arrow is that the mapping system pointed to me that the flutter was coming below the left side pulmonary vein. I ablated there and nothing happened to the flutter. The flutter continued. At the middle row is the modeling study that was done before the patient was brought to the EP lab. And the model showed me an isthmus. In the next slide, I'll show you a video of that. And I ablated there, which is shown in the panel D, and the flutter terminated. So there is some promise. We published this as a small series. We're going to do a much bigger study as we optimize these modeling parameters. But there is some future in terms of using all the data and scar information to make these models and give a sense to the electrophysiologist ahead of time before the patient comes to the EP lab to see where these circuits are. And here in the middle row, if you look at this particular channel, oh, now I've messed it up. Hopefully this plays the video. Here it is. In this particular panel, this is just showing this arrhythmia in the model sort of going through this isthmus on the posterior wall, going between the pulmonary veins and sort of a figure of 8 re-entry leading to flutter in this particular patient. And I ablated right there at the isthmus of this, and that terminated the flutter. So let me end by just saying ablation can be first line for select patients. That's now made it to the guideline in class 1 indication. Patients with heart failure should be considered aggressively for rhythm control, again, borne by data over a lot of years. PFA holds a lot of promise, but we don't have long-term data. So that needs, we will obviously see that over time. There is some question about how durable the lesions are over time. So we'll get answers to those in the years to come. Left atrial appendage devices provides an alternative to patients who cannot tolerate oral anticoagulation, but just a word of caution before we expand that big time to lots of patients. I'll end there. Thank you. I'll take any questions.
They're on Vercuvo, they've had iron infusions, the whole shoot match. But they're AFib patients, they're on antiarrhythmics. It'd be worthwhile to try to ablate these patients and see if it would help them.
Yeah, I mean, obviously, you have to factor in how big the left atrial size is, how many years they've had the AFib for. Again, it's a discussion. But I would keep ablation in your armamentarium of dealing with these patients. Absolutely.
Yeah. I mean, wouldn't that be the thing to do, those ablate?
Yes,
Right.
yes,
Yeah.
absolutely. An aggressive rhythm control is very much to be considered for these patients. And as we get better and sort of doing better for these patients, I think more and more people are getting comfortable sending these patients for ablation. At least that's what we are seeing in our group in lots of places.
I guess I have a twofold question. So one, you know, I've dealt with a lot of EP physicians now over many, many years, and it seems like, you know, there's different talent levels and confidence levels, their abilities to ablate. To me, I can't think of a scenario where I would ever want to be an AFib or even have paroxysmal AFib, just given the atrial myopathy, you know, the fibrosis and the structural changes. You know, if I was in the right hands with an EP doctor who had a very high success rate, even if I had minimal AFib, I would want it ablated. So that's kind of one thing. Just, I mean, I favor early ablation in almost every scenario. But one thing I notice is really, it's not consistent, is what you do with anticoagulation after you ablate. So most of the guys that I use, they'll stop anticoagulation if they feel successful, if the left atrial size isn't huge and it was more paroxysmal rather than persistent. You know, they're very confident. I just went to an AFib conference a few months ago, and this guy who's done 1,000 zillion ablations says he never stops it. He said that there's just too much residual AFib for him ever to feel comfortable. And then I've seen people do both, where they'll do an AFib ablation and go ahead and pop a Watchman in. You know, I've seen that kind of that hybrid thing. So I don't know how you feel about that.
Yeah, I mean, obviously some of them are complicated sort of issues, and there's lots of debate in our world, as you can imagine, of what to do with anticoagulation post-AFib. And where I come on it is, obviously you have to look at the patient. Not everybody is different, right? So if somebody is young, CHA2DS2-VASc is very low, and you're quite confident that they're not having AFib, and they were highly symptomatic of AFib before you did the ablation, so you have a very good marker whether they have recurrence or not, right? So in those patients, I feel comfortable saying, hey, you're fine, you're not having any AFib, I'm fine stopping the blood thinner. But on the other hand, if somebody who's not very clear of their symptoms, they have other high CHA2DS2-VASc score risk, I'm more hesitant in stopping their blood thinner, and I need lots of objective data before I say I'm going to stop the blood thinner. Does that mean just a 30-day monitor is enough? Do we put a loop recorder? Again, that to a certain extent is a discussion that I have, and higher their risk of stroke, higher the likelihood of AFib coming back based on comorbidities and other factors, less likely for me to stop the anticoagulation. So there isn't a one fixed answer, at least in my practice, which is also the norm for a lot of people. To address your sort of comment about just putting an appendage occluder at the same time, I'm not in favor of it. I don't do that. I don't think the data is clear. I think, as is usually the case, I think we push some of this technology too much. I think we need to take a step back and deal with it. And I showed you the data. The reason I showed you that study with 4% clot was to make that point that in some patients, you might actually be harming them to some extent by putting this stuff in.
That 4%, that's not with the newer occluders though, right? Isn't that?
It's an old data, obviously.
Yeah.
There's new iteration of everything coming out all the time. Over time, we'll find out how better they are in terms of the clots.
And one other thing, and I'll stop, is the patients who have a contraindication to anticoagulation where you want to put an occluder in, right? Or like their fall risk is too high. But I have a lot of patients that simply don't want to be on anticoagulation, and they want to be ablated so they don't have to take it. And I would say, there's nuance to everything, and something that you just said, like, hey, if their CHADS vascular score is high, their risk of paroxysms are higher. I asked the EP doc if he would put a loop recorder in, like after the ablation, just because of that, you know, that risk. So you think that's pretty reasonable?
Yeah, no, that is very reasonable to put a loop recorder to really see if they're having AFib or not. And based on that, you can do a very informed decision whether you want to continue the blood thinner or not. When I have patients who come to see me for ablation just for the sake of getting off the blood thinner, I do not follow that practice, because then it's also the guidelines. It's because the success, at least for getting rid of AFib completely, is not that huge. Even so, the data I showed with the cryo with paroxysmal patients, you saw if you use, again, you can argue how good the 30-second cutoff is, but if you use that as cutoff, then the success is only 65%. Right? Nobody would want to be ablated knowing sort of, again, the complication rates and stuff have gone down quite a bit, but with a success of 60-65% of getting rid of AFib completely, would you feel doing that just to stop the blood thinner? The answer would be no.
That 30-second rule, that's after a certain period of time, right?
So that 30-second rule is only for studies. It's for control, for trials. What do you use as a definition to say they have recurrence of AFib?
Right, but there's tons of people who have 30 seconds of AFib within a week or two.
Oh, yeah, after 3 months. You're
3 months.
Right.
Okay.
After the 3 months, sort of the blinding period, after the 3-month period. Yes, of course.
Thank you very much.
Yeah. Well, time will tell. I mean, obviously, there have not been that much of data out there.
Saying we do not need to anticoagulate, like even with P2 Y12s.
Right, and that practice is changing over time as we are getting more and more data. People are doing less and less of that over time. Thank you. Thank you for sticking out to the end.